So isoniazid is probably the first drug you need to know. It's very similar to pyridoxine. It inhibits cell wall production in M. tuberculosis, so the bacteria itself is not able to make its cell wall. Resistance develops, and it's rapidly developing if you're not using it with other medications. It's often due to a point mutation in one of 2 points that code for the critical enzymes responsible for making the cell wall. It is not effective against a lot of dominant organisms, however. In terms of the toxicity, the biggest thing that we are concerned about is neurotoxicity, which includes restless leg, peripheral neuritis, and those things we treat with vitamin B or pyridoxine. Hepatotoxicity is a concern as well. You can develop abnormal liver function tests, you can develop jaundice, and you can develop some hepatomegaly. So it's important that you monitor liver function tests regularly and you do a clinical exam on these patients too. One of the problems that we have with isoniazid is that its interactions with other medications, which include carbamazepine, phenytoin, and warfarin. So clearly this agent is working through the cytochrome system. One of the other issues that we worry about is hemolysis in those patients who have glucose 6-phosphatase deficiency. So this is an important part of your history before you're prescribed this drug. Another agent that we use in TB treatment is rifampin. So rifampin, you became fairly familiar with it when we were talking about inducers and inhibitors of cytochrome. It's very bactericidal against Mycobacterium tuberculosis. Now remember that the drug itself is quite orange colored, so it may discolor urine and it may discolor the feces, and sometimes your patients come in freaked out because they're peeing out orange. Just reassure them that's totally normal with this pill. It's usually used in combination. Sometimes we used it individually, but quite frankly, in the last 15 years, I've never seen it used individually. It's given as prophylaxis to family members of TB patients on a fairly regular basis now. In terms of how it works, it inhibits DNA-dependent RNA polymerase, and rifampin is the prototypical cytochrome inducer, as I mentioned before, so you'll hear a lot about this agent way out of proportion to its level of use in the community. In terms of resistance to rifampin, it is due to changes in drug binding of this polymerase. In terms of toxicity, the toxicity is really light chain proteinuria, skin rashes, and thrombocytopenia. You can also get nephritis and hepatic dysfunction too. Rifabutin is in the same class as rifampin, and it's equally as effective as rifampin, and it's actually preferred in HIV-positive patients because it has fewer cytochrome inducer effects. Rifamycin is also another agent in the same drug class, and we've used this in traveler's diarrhea in the past. Let's move on to ethambutol, or ETB. It is an inhibitor of arabinosyl transferases. Now, this particular protein is a component of cell walls. It is well absorbed and it's excreted in the urine, and it's always given in combination with other anti-tuberculous agents. The toxicity of ethambutol is usually reserved to visual disturbances. So patients, interestingly enough, complain of red or green color blindness. They may also develop an optic neuritis or retinal damage. So a very close evaluation of their ocular system, their visual system, is really important. Sometimes patients may also develop headache, and they can also develop confusion and hyperuricemia. One of the other rarer complications of this medication is peripheral neuritis. Pyrazinamide is always given in combination with other drugs. It's well absorbed, it's excreted in the urine, and its half-life is increased in liver or renal failure. Pyrazinamide has non-gouty polyarthralgias, and that's really common. Up to 40% of patients develop this. They also often will get an asymptomatic hyperuricemia, myalgias, rash, and hepatic dysfunction. Remember that you want to avoid this agent in pregnancy. Streptomycin is an aminoglycoside. I alluded to it earlier. It's used in resistant strains of tuberculosis, and its main concern, like all aminoglycosides, is renal toxicity or renal dysfunction. And of course, we mentioned before that aminoglycosides are involved with otosclerosis and ototoxicity, including some auditory, as in not being able to hear, toxicity. Amikacin is used in drug-resistant TB infections. We also use ciprofloxacin and ofloxacin in drug-resistant TB, and we can use it in combination with the other TB drugs. Ethonomide is a drug that is very similar to isoniazid. It's used in patients who have isoniazid-resistant strains of TB. Now, para-aminosialic acid, or PAS, is also used, but rarely now because the resistance is so common. It's a relatively toxic agent, causes lots of GI irritation and peptic ulceration. You don't need to know this for your exam, but in case you ever come across this, you just know that it's one of these agents that we used to use a lot, but not so much anymore.